Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube and live streaming to YouTube and recording the session. Please feel free to ask questions in the chat box as we go along and they will be addressed. I'm honored to introduce our mentor for today, Dr. Raymond Cross. Dr. Cross is a professor of medicine in the Division of Gastroenterology and Hepatology at the University of Maryland, Baltimore. He also serves as the director of the Inflammatory Bowel Disease Program at the University of Maryland School of Medicine, and also serves as a co-director of the Digestive Health Center at the University of Maryland Medical Center. Dr. Cross completed his residency in internal medicine and gastroenterology at the University of Maryland and Baltimore VA Medical Center. Our esteemed mentor has also authored over 100 journal articles, reviews, and book chapters. His research interests include application of telemedicine in the care of patients with IBD, reducing disparities, outcomes research, and clinical trials. Now I'd like to request Dr. Cross to begin today's session. Thank you.
Thank you very much. Let me see if I can share my slides. All right, so over about the next 30 or 35 minutes, I'm just going to give everyone an overview of inflammatory bowel disease. Let's see if I can get my slides to advance here. Okay, so inflammatory bowel disease is comprised of primarily two illnesses, ulcerative colitis and Crohn's disease. There is about 10 or 15% of patients that have what's called inflammatory bowel disease, type undetermined or indeterminate colitis. And that's basically patients with disease involving the colon that has both characteristics of ulcerative colitis and Crohn's disease, where we can't really determine precisely which they have. So it's sort of a waste basket category. These diseases are fairly common, with an estimate from the CDC now that there's about 3 million people in the United States with IBD. So that would be about 1 in 100 approximately. So it's fairly common, and the incidence seems to be increasing, particularly in developing countries. And I mentioned developing countries. In the past, we thought that Crohn's and colitis was primarily a disease of developed countries, as you can see on this map. But as more and more countries become, I guess I'm going to do quotes, developed, we're seeing increasing incidence in other countries as well. And even within countries, we see this north-south gradient, and we're not exactly sure why that exists, with a higher incidence and prevalence of disease in northern countries compared to southern countries. Or let me say northern states and southern states. As you can see, it affects men and women approximately equally. The most common age of diagnosis is in the age 20s to 30s, but it can occur. 15% of patients are diagnosed in adolescence or childhood. We even see very early onset IBD in very young children. And we can also see 10 to 15% of diagnoses over the age of 60. So it doesn't really spare the young or the old, but the most common age of diagnosis is in the 20s and 30s. What are the risk factors for these diseases? So unfortunately, it's not the same for both types of diseases. The most important risk factor here is smoking. Smoking is actually protective for ulcerative colitis, which is one of the few illnesses that actually makes the disease better. So if a patient says that I stopped smoking 6 months ago and I then develop bloody diarrhea, that's ulcerative colitis until proven otherwise. Conversely, smoking is more common in patients with Crohn's disease and makes the course of Crohn's worse. There's other risk factors. There's some studies showing that an appendectomy, removal of the appendix, is protective for ulcerative colitis. As I said, this is more common in developed countries. So higher sanitation can be associated with diseases like Crohn's. We know that diet is important, but what in the diet is what one specific element of the diet is associated with disease is not known. There's some studies linking oral contraceptives and breastfeeding, but smoking, I think, is the most important thing to remember here. And thinking about causes, if someone tells you that they know precisely what the cause of Crohn's and colitis is, you really should run away, because no one really knows why this happens. Clearly, you have to have the right genetics or the wrong genetics to get this disease. But remember that only 1 in 6 patients have a family history of Crohn's or colitis. So it's not a simple, it's clearly not a single gene association. It's going to be a polygenic association, and it's not, that in and of itself will not lead to IBD. We know that the intestinal microbiome is incredibly important. There's many studies showing that in patients with Crohn's and colitis, that their microbiome is different from patients without IBD, but that also in and of itself is not enough. Clearly, I mentioned that in developed countries, it's more common. So it's something in the diet that we have, processing of foods, et cetera, that is also important. So you put all that together, and then some type of injury occurs. That could be taking anti-inflammatories like Motrin. It could be a course of antibiotics. It could be an infection. It could be stress of COVID, so severe stress. Some injury happens, and in the patient with the right genetics, the right microbiome, eating the right diet will trigger onset of IBD, and then that immune system kicks in and it doesn't turn off. But there's not one precise cause of this disease. So I mentioned genetics. Genetics is important. It seems to play more of a role in Crohn's than it does in ulcerative colitis. I mentioned already that 1 in 6 patients will have a positive family history. And it's interesting that in Crohn's in particular, not only is it more common to have a relative with Crohn's, but it's also the type of Crohn's that a patient has will coexist in the same family. And I'm going to talk about types of Crohn's in a second. I mentioned already that it's not one gene, it's multiple genes. And the first gene that we really uncovered was this NOD2 mutation on chromosome 16, and that's really associated with small bowel Crohn's and stricturing Crohn's disease. But there's now been multiple genes associated with Crohn's disease. I mentioned the microbiome. The microbiome is very complex. I'm sure that many of you have heard of probiotics, and that industry is I would assume is $1 billion industry, and we really don't understand it very well. What we can measure in the stool is different than what is lining the intestinal mucosa. And it's also affected by when you take a bowel prep for a colonoscopy. But trying to simplify this a bit, we think that there are protective bacteria, things like lactobacillus, bifidobacterium, and non-pathogenic E. coli. And there's injurious bacteria like Bacteroides, Enterococcus, and different forms of E. coli. In normal people without IBD, there's a nice balance or yin-yang between these protective and injurious bacteria. But when you have antibiotics or an infection, this can get tipped in the scale of the bad bacteria, which can trigger IBD. And I already told you that in general, patients, even patients before the onset of IBD, that their microbiome is different, and the scales are tipped more on these bad bacteria than the good bacteria. So I mentioned that in general, most of the people on this call are going to have a normal gut. So there's a tolerance between the bacteria in your intestines and the intestinal immune system. there is some trigger. We mentioned it could be stress, it could be infection, it could be antibiotics, it could be anti-inflammatories. You get an acute injury. Now, in a normal host with genetics that don't predispose you to Crohn's and colitis, you overcome the acute injury and you go back to normal. But in a patient that's genetically susceptible, you don't overcome that acute injury, you fail to repair, and you develop chronic inflammation. So that's basically the pathogenesis. And so it's probably unsatisfying that there's not an easy answer. Now, thinking a little bit about the clinical presentation, which is probably more interesting, one of the first things that you think about when you see a patient with gastrointestinal symptoms is this an organic cause or is this something that's functional? Because irritable bowel syndrome is far more common than Crohn's or colitis. And irritable bowel syndrome can affect 15% of people in the United States. So it's very, very common. So how do you distinguish these two diseases? Well, oftentimes the symptoms can help distinguish them. So for example, patients with irritable bowel syndrome do not have blood in their stools. They don't wake up at night to go to the bathroom. They typically don't have fecal incontinence. If you look at the stool itself, you don't see white blood cells, which is common when you have intestinal inflammation in the stool. You don't see occult blood in the stool, so you can actually test for microscopic blood in the stool. If you check blood work, patients generally are not anemic. They don't have elevated platelets. Their inflammatory markers like CRP and sed rate are not elevated. Their albumin, which can be a marker of nutrition, but also can be a marker of just being ill in general, is typically normal. Patients with irritable bowel syndrome don't have weight loss. They don't have systemic symptoms like fever. Patients with Crohn's can have perianal involvement, so they can have a fissure or perianal fistula or perianal abscess, and you don't see that in irritable bowel syndrome. So when you go into medical school and then when you eventually become, a resident and then eventually become an internist, these are some of the things that you think about right away in a patient who does not yet have a diagnosis of Crohn's and colitis. The other thing that you have to think about is, could this be an infection? So my family and I just came back from Mexico. So if I had an acute presentation of diarrhea, you would think right away that this could be an acute infection. Well, how do you differentiate that from Crohn's and colitis? So typically acute infections are going to have a short duration. They have an abrupt onset. And typically, not always, but typically blood work is going to be normal. We often don't do procedures in these patients to make a diagnosis, but sometimes this happens. And in general, when you do biopsies of abnormal tissue, you're going to see a predominance of acute inflammation without chronic inflammation. Conversely, patients with Crohn's and colitis typically have a longer duration of symptoms, usually more than a month. Often these patients will have symptoms for months, sometimes even a few years. It's not so abrupt, the onset of the symptoms in most cases. They often will have abnormal labs. They could be anemic, have thrombocytosis, which means elevated platelets, high C-reactive protein, which is a marker of inflammation. We're going to show some pictures here, but when you do a colonoscopy and you do a biopsy, not only will you see acute inflammation, but you will see chronic changes. So you're going to see changes in the crypt architecture. You're going to see basal lymphoplasmacytosis. So the buzzword is going to be acute and chronic inflammation, not just acute inflammation. So we'll start with ulcerative colitis first, because the presentation is much more homogeneous compared to Crohn's. It almost always, and I never say always, but almost always presents with bloody diarrhea. Sometimes patients will come in and complain of constipation and rectal bleeding. And when you really question them further, what they have is this symptom called tenesmus, where they feel like they have to go to the bathroom, they sit on the toilet, and what they produce is blood and mucus. They can't really have a bowel movement. And that's called tenesmus. And one of my mentors calls this dry heaves of the rectum. I'm sure everyone on this call has had dry heaves at some point in their life. And it's really an uncomfortable symptom for patients, and it can be really quite painful. I told you that most patients have a more insidious onset of their symptoms, but you can have a more acute presentation where patients come in quite ill. They can have fever, they can have high elevated heart rate, low blood pressure. Typically, abdominal pain is not a prominent symptom in ulcerative colitis. Cramping when you go to the bathroom, yes, but severe pain really should make you think of an alternate diagnosis. And if a patient with ulcerative colitis comes in with nausea and vomiting, that's a very concerning sign. So that can be an early sign that the colon is dilating. And that's called toxic megacolon. And in that case, those patients often have to have surgery or removal of the colon. Ulcerative colitis, if you're trying to distinguish it from Crohn's disease, only involves the colon in general. It almost always involves the rectum, and the involvement typically goes from the rectum proximal. So it starts in the rectum, and it may just end in the rectum. It can involve the left side, which is up to the splenic flexure. It can cross over the splenic flexure and go into the transverse colon, which is extensive colitis. And when it gets into the right colon, we call that pancolitis. It's typically more of a superficial inflammation, and the inflammation is generally continuous. So if it starts in the rectum, you see a continuous area of inflammation until it stops. And often you can see a sharp demarcation between inflammation and normal tissue. And you only really see that in ulcerative colitis. I mentioned that the extent of disease is how we classify ulcerative colitis. It's typically broken into three categories: isolated proctitis, left-sided disease, and extensive or pancolitis. Why is that important? It's important because patients that have more extensive disease are more likely to be hospitalized. They're more likely to have a colectomy or removal of the colon, and they're more likely to develop colon cancer over time. Now, the other thing is that when you have more extensive disease, those patients are more likely to have abnormal labs, whereas a patient with left-sided or proctitis can have horrible symptoms. Their colonoscopy can look terrible, but their labs can be completely normal. And this is actually a problem because inexperienced providers could look at lab tests and say, well, this patient's not that sick. And in fact, they can be quite sick and have completely normal labs. So ulcerative colitis, it's actually a little bit, I think it's inappropriately named. When you think ulcerative colitis, you imagine these big ulcers. I should have actually shown you guys a picture of normal, but these are clearly not normal. Ulcerative colitis is a more superficial inflammation. So in a normal colon, you're going to see a nice shiny mucosa with normal blood vessels. You're not going to see any redness. You're not going to see any bleeding, and you're not going to see any ulcerations. And you can see in these two images, this is clearly not normal. So you can't see any vascular pattern in these pictures. You can see that there's clearly redness. The white on these is ulcerations. And you can just imagine that if you bump the lining here, that you can get bleeding of the tissue. So these are classic pictures of a patient with moderate ulcerative colitis. So very classic looking. And I describe it as sort of like a sandpaper look to the intestine of the colon. And I'm going to show you some Crohn's pictures, which are going to be much different. So we mentioned acute inflammation. So I don't know if my I don't know if you can see my pointer here, but this is generally a normal crypt on biopsy. And this is what we call a crypt abscess. So this is all neutrophils or pus. And you can see that this was once a crypt, like here, and it's now completely filled with pus. So this is a crypt abscess. I mentioned architectural distortion. Again, I should have shown you guys a normal picture, but this is clearly not normal. So what you can see here is an expansion of the basal side of the cell with lymphocytes and plasmacytes. And then these are the crypts, which are branching. If you look at this under a microscope, and one of our best pathologists always laughs when I'm reviewing slides with our trainees. If you can make animals out of this, so you can imagine this looks like bunny ears out of the crypts, then that's a patient who has chronic inflammation. And it's a funny little thing to say, but it actually is really important for someone who's not looking at these slides all the time. And I mentioned basal lymphoplasmacytosis. So you generally don't see this expansion down here in patients who have some kind of acute injury, and it's more synonymous with Crohn's or colitis. And by the way, what I just showed you does not distinguish between Crohn's and colitis. Both illnesses can have those features. Now, shifting to Crohn's, how do you distinguish Crohn's from ulcerative colitis? There's a number of ways. So we mentioned perianal fissures, fistulas, or abscesses. So if you see those in a patient with intestinal inflammation, that's consistent with Crohn's disease. Only about 20 to 30% of patients will have rectal involvement with Crohn's. So if you see rectal sparing, that's more suggestive of Crohn's. I mentioned that the inflammation in ulcerative colitis is continuous. In Crohn's disease, we're much more likely to see skip lesions. So you might see some involvement of one segment of the colon, another segment of the colon, and the ileum. And that is more consistent with Crohn's. I mentioned the ileum, so small bowel involvement. So if you get involvement of the ileum, jejunum, duodenum, those are the three segments of the small bowel, that would be consistent with Crohn's. I'm going to show you some endoscopic images that are going to be helpful. If you develop a narrowing or a blockage like a stricture, that's consistent with Crohn's. If you develop an internal fistula, so that in here, I'm documenting a connection between the ileum and the sigmoid colon, that is consistent with Crohn's. And then on biopsies, you can see granulomas. Now, it gets a little more complicated, but in general, if you hear granuloma, that is going to be consistent with Crohn's disease. What about the anatomic distribution? So most commonly, patients will have involvement of the ileum, which is the end of the small bowel, as well as some segment of the colon, and that's called ileocolonic Crohn's, and that affects about 45% of patients. About a third of patients will have involvement of the ileum only, and then about 20% of patients are going to have involvement of the colon alone. And that's the group of patients where it can be hard to figure out. It can be hard to figure out if this is Crohn's or ulcerative colitis, and that's a group that you may fall into this wastebasket category of indeterminate colitis. Now, if I haven't put you to sleep yet, you're going to notice that those numbers do not add up to 100%. So there can be patients that have isolated upper tract Crohn's. So anything above the ileum is considered upper tract. So jejunal disease, duodenal disease, gastric disease, esophageal disease. If you have that alone, that would be isolated upper tract. In addition, about 2% of patients will have no involvement other than around their bottom. So what we call isolated perianal disease. So in Crohn's disease, there's three basic types of Crohn's that you can have. The first type is called non-stricturing or non-penetrating or inflammatory disease. So these are patients that do not have a stricture or internal fistula. They often present with abdominal pain, non-bloody diarrhea. So the diarrhea in Crohn's is typically more non-bloody. And then they may have systemic symptoms like fever, nausea, vomiting, weight loss. That can be very common. The second type is called stricturing or obstructing Crohn's. These patients have a narrowing somewhere in their bowel, more commonly the small bowel, but it could be the colon. And this is tough because early on, patients with stricturing Crohn's can very much present like irritable bowel syndrome patients. So these patients will often have pain after eating. They can have abdominal bloating or distension. They might have loud bowel sounds, which are called borborygmi. In late stages, when they have a more severe narrowing, they can have nausea and vomiting. And then often what happens is that they'll get an episode of pain, and then when the obstruction resolves, they will get diarrhea afterwards. And again, those symptom complex is consistent with irritable bowel syndrome, so it can be hard to tease out. And a patient will often tell you that I'm flaring, and they'll describe these symptoms of distension, loud bowel sounds, pain. I feel like I have to go to the bathroom, but I can't, which is called obstipation. And then they'll have significant diarrhea, and they call that a flare. That's not a flare, that's an episode of obstruction that is resolving. And in late stages, these patients will lose weight, and they can even have nocturnal symptoms that wake them from sleep. This is a form of perforating Crohn's. So perforating Crohn's means that you have a fistula from a segment of intestine to another loop of intestine, to the bladder, to the abdominal wall, or what we call an enterocutaneous fistula, or blindly into the abdomen, where patients will form a collection of infection or abscess. But sometimes Crohn's can present very suddenly. It can look like appendicitis, and in fact, what you'll have is terminal ileal inflammation, which is right next to the appendix, with a fistula or sinus tract into the abdomen where it looks like appendicitis. And we see this a few times a year at our medical center, where a surgeon will open a patient up expecting to see an inflamed appendix, and they see Crohn's, and they close the patient up and say, oh, we're wrong, and they call us to confirm the diagnosis. We mentioned perforating disease. So this is what you're seeing here is a small bowel to small bowel fistula, but fistulas can go from a segment of bowel to the bladder, and these patients can actually have recurrent urinary tract infections. When they urinate, they can actually pass fecal matter or pass gas through their urethra or penis. These blind fistulas can go into your back muscles, and you can see it have a zoous abscess. They can go to the abdominal wall. Perianal and rectovaginal fistulas are not really categorized as penetrating or perforating Crohn's. They're actually what we call perianal involvement, so I don't want to confuse this. And to make it a little more complicated, we really think about these fistulas as two types. So oftentimes you'll see a stricture downstream, so below the fistula, and your body, in a maladaptive effort to relieve the obstruction, can form a fistula to another loop of bowel to decompress the bowel above it. So some people will call that stricturing and penetrating disease. Conversely, there are some patients that have these deep ulcers that just go through the wall of the intestines to form a fistula. I generally just, if you have a fistula internally, I call it penetrating, and I don't really worry about the stricturing aspect. But it is important when you're making decisions about medical treatment versus surgical treatment. So I mentioned perianal Crohn's. I have a few gross pictures that I was going to show, but since it's the morning time, I decided not to show you my grossest pictures. But this is basically your anus here, and this is the rectum above it. And a perianal fistula typically comes from the anus to the skin surface on the outside. And on the my right, your right as well, I guess, you can see a branching fistula, which is very unusual for a patient who doesn't have Crohn's. And here you can see a single fistula on the left that's going into an abscess cavity. So any of us can get a simple fistula. But when you see a fistula with these branching characteristics, it's almost always going to be consistent with Crohn's. I did show you one gross picture. So this is you can see this purulent drainage on the right side of the figure. And then you can sort of see that dimple above the pus area. And that is going to be an external opening of a perianal fistula. So I'm going to show you some endoscopic pictures. These aren't great pictures, but I'm almost certain that everyone on this call at some point in your life has had a canker sore in your mouth or an aphthous ulcer. And the early Crohn's lesions look exactly like that. So there are these small, less than 5 millimeter ulcerations, which have a nice clean base, often will have this halo of red around it. And you can see this is maybe on the bottom right is more advanced, but still generally small ulcers. And importantly, the intestine next to it is normal. So you have ulcer with normal tissue adjacent. Now you're gonna hear this buzzword called cobblestoning. So ignore the left and the middle panel, just focus on the cobblestone street. So if you're in Georgetown or if you're in Baltimore and you're familiar with what the cobblestone is. So when they say cobblestoning for Crohn's, what you're supposed to think about is the filler between the bricks are the ulcers and the bricks are the normal tissue around it. So take a good look at the cobblestone path on the far right. And then I'm going to show you what cobblestoning looks like in the intestine. So, and this may not be normal tissue, but you can see that the ulcers are very different than ulcerative colitis, right? The ulcerative colitis patients, you definitely got the sense that they're more in the superficial lining and the tissue is involved continuously. Here, you can see these breaks where you have ulcers with non-ulcerated tissue next to it. So this is very typical for a patient with more moderate to severe Crohn's disease. So I showed you some pictures, some biopsy pictures of patients with acute and chronic injury. You can see that, you see that in both Crohn's and ulcerative colitis. How can you distinguish Crohn's from ulcerative colitis on biopsy? So on a biopsy, you're not going to see transmural inflammation because that would mean I would have to biopsy through the entire layer of the colon, which would cause a tear or perforation. So you can only really see transmural inflammation on a surgical specimen. And what you're seeing here is an example of transmural. So on the upper part of this picture would be the mucosal lining. And as you go to the bottom part of the picture, you're going to go through the muscle wall and into the serosa. So this is an example of transmural inflammation. And then I mentioned the granuloma. So granulomas impact about 40 to 60% of patients with Crohn's disease. It is a little bit more complicated because you can actually see a granuloma in ulcerative colitis, but those typically occur within the crypts themselves, whereas granulomas in Crohn's are isolated outside of the crypt. So if you see a granuloma in a patient with intestinal inflammation, it's almost always going to be consistent with Crohn's disease. Now, I've just focused on the intestines, but the reason that you have to remain a good overall doctor to take care of these patients or a good internist is that Crohn's and colitis can also have manifestations outside of the intestines. So I mentioned canker sores or aphthous ulcers or mouth ulcers. So that is fairly common in both diseases. We call that aphthous stomatitis. Patients can have inflammation in their eyes, most commonly episcleritis and uveitis. The arthritis that patients can get is very interesting. So they can get a peripheral arthritis involving the large or small joints that can look like rheumatoid arthritis. They can also get an axial arthritis. So they can have inflammation of their sacroiliac joints or their butt joints, and they can have inflammation of their spine, which is called ankylosing spondylitis. There's two skin diseases that they can get. One is called erythema nodosum, which looks like bumps on your shins, even though you haven't bumped into anything. These are typically reddish or bluish nodules on the shins that are exquisitely painful to touch. And then patients can also get ulcers on their skin, which is called pyoderma gangrenosum, which is exquisitely painful. When I say vascular complications, when you have a lot of inflammation, like you can see in Crohn's and colitis, patients will can often have a blood clot or a DVT in their lower extremity, which can embolize to their lungs and cause a pulmonary embolus. So that's actually, unfortunately, fairly common in our patients that are quite sick. So I don't know if you can see this well, but this is basically the base of the tongue. And on both the left and the right, you can see these little white ulcers. Those are classic aphthous ulcers, and it's actually misspelled. It should be APHTHOUS. But that doesn't in and of itself mean that you have Crohn's or colitis. But you can certainly see this in our patients that have active Crohn's or colitis. Crohn's and colitis is more common in patients that are white, although we do see this in underrepresented minorities as well. So in general, patients that are white are more likely to have bone loss, but we can see bone loss in all of our patients, and it can be from the disease itself. So the inflammatory molecules that are present can adversely affect your bones and put you into more of a bone loss instead of bone building environment. Steroids, which are often used to treat Crohn's, have a negative effect on your bones. And when you have a diarrheal illness, often patients are confining themselves to the house. So they're not outside, they're not getting sunlight, they're not getting weight-bearing exercise. So the reason that patients get bone loss can be for multiple reasons in Crohn's and colitis. I mentioned the arthritis that patients can get. So typically, we were taught that it affects a single or a few large joints, and it coincides with a flare of the Crohn's or colitis, and you treat the Crohn's or colitis, and the inflammation goes away. And that is true, it does happen. But there's also a more of a symmetrical arthritis that affects your small joints. And that can actually present before you're diagnosed with Crohn's or colitis. It can present when your Crohn's or colitis is well controlled. So it can be actually fairly confusing. You also are patients with Crohn's and colitis are more likely to get involvement of their tendon sheaths. So we can see inflammation around the Achilles tendon. We can see what they call sausage digits, so where your fingers look like little sausages. So the inflammatory arthritis in our patients with Crohn's and colitis is interesting, and it can be somewhat, at times it can be somewhat difficult to treat. On the left are examples of erythema nodosum. It's easier to see in real time, but you can see these sort of look like bruises, but this patient didn't bump anything. This just happened spontaneously. And this tends to occur when the Crohn's or colitis is active. And when you treat the Crohn's or colitis, this tends to get better. You can see here that this is an ulcer. Again, this can occur anytime. So your Crohn's and colitis can be under complete control, and you can just develop an ulcer. And this often is caused by an injury. So a patient will have something that seems relatively innocuous, and and then they look down the next day and they have an ulcer on their skin. So this is pyoderma gangrenosum, and it's really nasty and can be difficult to treat. It's hard to do eye pictures. Again, some of the eye disorders you can only see with special equipment. But I think what's important to know is if a patient with Crohn's or colitis has a red eye that's painful with some alteration in their vision, that's an ocular emergency. So that's where we need our ophthalmologist involved very quickly, because these inflammatory eye conditions can result in vision loss if you don't diagnose and treat them promptly. So I did mention the liver. So the liver is important. And you probably don't know what you're looking at here, but these are images of the biliary tree. And on the right, you're seeing examples where there are strictures. So this is primary sclerosing cholangitis. So most patients with primary sclerosing cholangitis have underlying inflammation in their colon, either most likely ulcerative colitis, but it can be Crohn's colitis. Fortunately for us, most patients with Crohn's or colitis don't have PSC. So you can have PSC without IBD, but it's much more common, and a diagnosis of PSC should prompt you to look for underlying IBD. This typically presents with right-sided abdominal pain, jaundice or yellowing of the eyes, yellowing of the skin, fever, so you can have an infection. So we call that, well, in someone without PSC, we call that cholangitis, but you can have an infection. It can eventually result in damage to the liver or cirrhosis and require liver transplant. The other thing that can happen is with chronic inflammation anywhere, you're more likely to develop cancer. In the biliary tree, that's called cholangiocarcinoma. And unfortunately, that's almost always fatal. And if you're football fans, this is the disease that Walter Payton had. So he had primary sclerosing cholangitis and unfortunately developed cholangiocarcinoma and died. He did not have underlying IBD. I mentioned cancer. So the most common cancer that patients have with chronic colitis, Crohn's colitis or ulcerative colitis, is colon cancer. So the longer you have the disease, the more extent of disease you have. Patients with PSC have a very high rate of colon cancer for reasons we don't understand. Patients who have a family history of colon cancer have additional risks. So in our patients with chronic colitis, 8 to 10 years after we make the diagnosis, we typically start doing fairly regular colonoscopies to look for precancerous lesions, and sometimes we find cancer, but the goal is to find the precancerous lesions, remove them if they're visible so a patient doesn't develop cancer. Patients with small bowel disease can develop adenocarcinomas of the small bowel or lymphomas of the small bowel. Those are rare, but we do see them occasionally. And I think that's all I have. I didn't talk about treatments because treatment is a completely different talk, but I just wanted to give you an overview of what Crohn's and colitis is. And I'm happy to take any questions about Crohn's or colitis. I'm also happy to take any questions about, my path from being a kid growing up in Pennsylvania and Pennsylvania to wanting to become a doctor and how I got involved in Crohn's and colitis. So whatever you guys are interested in learning about, I'm happy to answer.
Thank you so much, Dr. Cross. Really appreciate your mentorship and teaching. I know I learned a lot. If anyone has any questions, they can feel free to ask in our chat box, and we will now begin our Q&A session.
Hi, Dr. Cross. My name is Robin. I'm a third-year PhD student in the Johns Hopkins School of Medicine. I'll start off our Q&A. If a patient has a prior family history or environmental stressors causing them to have a higher risk of IBD, what are some preventative measures they can take in their diet and lifestyle to help reduce this risk?
That's a great question. There are some studies primarily done in military patients, not military patients, in the military where they get regular blood draws where you can actually see a signal in your body's responses to bacteria in the colon. So there is actually a signal pre-diagnosis that a patient may be predisposed to Crohn's disease. But we don't use those in clinical practice, even in patients who have a parent or sibling with the disease. So we don't have really good diagnostics yet to identify high-risk patients, and we don't know what intervention to take to prevent the disease. But in general, if someone asks me, my brother or sister has Crohn's or colitis, what can I do? I think the simple answer is, we know that the diet is important. So what is a good diet to prevent Crohn's and colitis? So it's probably a diet that is less red meat, less processed food. So if you think about the grocery store, think about shopping on the perimeter of the grocery store and not in the inner aisles where all the processed food is. So eat more fruits and vegetables, eat less red meat. You don't have to not ever have red meat, but eat less red meat, eat more fish. So more of a Mediterranean type diet is what I would recommend. When patients have Crohn's or colitis, we know that the most important thing is that you don't smoke. If you have Crohn's, you come to the doctor regularly and you take your meds. That's the most important. But the diet that I mentioned probably plays some role. Exercise can be helpful. It doesn't mean going to CrossFit and flipping tires. It could just be walking every day for an hour, getting your steps in. Sleeping well can be really important. Stress reduction can be important. And there is a link between depression and anxiety and Crohn's or colitis. It's probably bidirectional, meaning that depression and anxiety can lead to IBD or a flare, whereas when you're flaring, you can be depressed or anxious. So it's probably bidirectional. So treating mental health appropriately can be important. But I think if you're just going to pick one thing, probably having a healthy diet with less processed food and less red meat is probably the most important.
So the same things that are good for all of us.
Agreed. Right. We all should be having a Mediterranean diet and eating less processed food. Exactly.
So IBD has kind of historically been classified as an autoimmune disease. Now that we know a little bit more about it, do you think that's the right classification for it?
Yeah, I think so. I mean, I do. I mean, and we see this, it's not just in the intestines, right? That we just have these autoimmune diseases that are far more prevalent in developed countries. So we have way more autoimmune diseases in developed countries than we have infectious diseases, right? And it has to be something about our lifestyles and the way we live, the things we put into our mouth. And the gut is thought to be a pathway for other autoimmune diseases as well, not just for Crohn's and colitis. And the microbiome can be distorted in patients who have other autoimmune diseases. So I think that classification is right.
Is IBD associated with HLA-B27, and how are they associated with each other?
So HLA-B27 is associated with ankylosing spondylitis. We don't typically order that test, at least in the GI world. I don't think I've ever ordered it, but in rheumatology, they may order it. But HLA-B27 is associated with ankylosing spondylitis. I can't remember the percentages, but the majority of patients with that spinal arthritis will be HLA-B27 positive.
So speaking of those extraintestinal manifestations that you mentioned, is that just a byproduct of the systemic inflammation caused by IBD, or is there some other factor that causes these symptoms?
Another great question. We don't know. So about 20 to 30% of patients will have extraintestinal manifestations. So it's not the majority, but still 20 to 30% is a fair amount. And it also can be, that number can be inflated, because if you just, particularly as you get older, when you get to my age, patients will have joint pain. And if you don't take the time to sort of tease out the symptoms. You can just inappropriately describe any joint pain as inflammatory joint pain with Crohn's or colitis. So that number can be inflated. In some cases, it can be up to 50%. But I think 20 to 30% is a better number. And we don't know why. There's some thought that there are shared antigens in the intestine and joints or eyes. So the inflammatory cells can target them, but we really don't know. Could it be genetics or shared? Absolutely. If you look at autoimmune conditions in general, there are a number of genetic abnormalities that are associated with inflammatory conditions together, not specific for Crohn's or colitis. We don't really know is the short answer.
Can you tell us about the applications of telemedicine with your patient population?
So if this computer crashes, I can't fix it. So I'm not an IT person, but when I finished my training or during my training in GI, I became very interested in research, and I didn't really have a mentor for research, so I was trying to find someone who could mentor me on a project. And at University of Maryland at the time, there was one of the faculty members was really interested in telemedicine and using remote monitoring to improve care of patients with asthma and chronic lung diseases. And so there was a nice synergy there with Crohn's or colitis, right? Because it's a chronic disease. It's not a respiratory disease, but it's an intestinal disease. So I started doing some work on remote monitoring to see if that could improve care in patients with Crohn's or colitis. So that is a form of telemedicine. So we've done a number of studies looking at that. And in general, what we found is that if you're getting really good care, adding that on doesn't make much of a difference, although it may prevent going to the emergency room and being in the hospital, which is still pretty important. And we're actually working now with a company called Synchronex to see if we can do remote monitoring for drug adherence to see if that can improve outcomes. So that's remote monitoring. But then around 2016, 2015, we also started doing virtual visits with our patients. I was one of the only people in our Department of Medicine that was doing this. I think initially it was one of the high-risk OB providers and myself that were doing this. She was getting reimbursed through a grant, and I set it up that we could do this through one payer would allow this to be reimbursed. So I've been doing this pre-pandemic for about 4 years before the pandemic. And then when the pandemic hit, of course, that's what we were doing. And, the reason I did this is University of Maryland's a referral center. We have patients from Southern Pennsylvania. We have patients from Delaware, some patients from West Virginia, DC, Northern Virginia. So we really, about a third of our patients have to drive more than 45 minutes to see us. So my goal was to try to expand our services and be able to provide care for more patients and make it more convenient. And patients really liked it, but it was really just a relatively small part of my practice. Now with the pandemic, it basically was 100% of our practice for a period of time. And now we're sort of backing it back down. And we could talk more about this if you like, but unfortunately, the problem with telemedicine is that before the pandemic, insurers wouldn't reimburse you for telemedicine. So if you did telemedicine, you weren't going to get paid for your services, which is not fair, right? And you have to get paid for your services to pay for your salary. The other thing is in the Northeast is that there's no interstate licensing compact. So I can't provide services to a patient in Pennsylvania without having a Pennsylvania license. So I said that I wanted to do this so I could take care of patients that were from far away from our center, But unfortunately, I couldn't do that. It was only the patients in Maryland, and still, like, there's patients in Western Maryland, Eastern Shore that benefited from it. But I would have to have a license in all of those states to be able to provide services, which is impractical from a time standpoint and a money standpoint. It's very expensive. And I hope that with the pandemic, that there would be some rational person in the government that would say, we're going to have a universal telemedicine license that will allow you to provide this service for $200 for 2 years, and you can do telemedicine for whatever state you want. But that hasn't happened. They basically shut it all down again, unfortunately. So it's sort of back. It's primarily back to where we were before the pandemic.
That's really a shame, because all these logistical issues with preventing people from being able to access such great care.
It is a shame. And the good news for Crohn's and colitis is that we have more and more medicines than we ever had. Unfortunately, that makes care more confusing. So how do I pick which medicine to give a patient? And payers are becoming more difficult to get some of these medications, particularly when it's not exactly at the dose that has been approved. So it's created a lot of stress on practices. So we're seeing more and more patients that are coming to us because the decision-making on medications is more complex. And it would be nice to be able to expand our services and to, be able to care for more patients. I'm not saying that telemedicine is a panacea, because it's not. We know that we can use it in a pandemic to continue care and keep quality care, but there are downsides to it. There are things that are important about seeing people in person. Just one example would be, point of care vaccination. So if we give patients that are give meds that are immune suppressive, we can prevent certain infections. So, just yesterday in the office, I probably gave 10 vaccines to patients. So you can't do that virtually. You can tell them to go to the pharmacy, but it's much easier in real time. As you could get a sense from what I was talking about, the care can be complicated because it's not just the intestines that we're talking about. So we have a dietitian, a social worker, nurses, infusion services, a psychiatry fellow. We have all of these services that are integrated into our center. And it's a little more challenging to do that when you're virtual. It becomes very fragmented. And then, as a provider, like I'm someone who definitely thrives on human interactions. And so in the pandemic, when we were just doing virtual visit one after another, it's very socially isolating for providers. So when we were able to start to come back in person, for me, it was very much a mood elevator. But I agree. It'd be nice if we could offer 10 to 20% of our visits as a virtual option, and to expand our services. But I don't think that's going to happen unless a senator or congressman really tries to push us, or people like you, or students that can bother people and say, this is really important. So unless someone really takes the lead here, I don't think it's going to change.
So if we shift gears a little bit, more generally, what inspired you to pursue gastroenterology and medicine?
So I grew up in a small town in southwestern Pennsylvania. I didn't have anyone in my family that had even gone to college. So I was the first person to even go to college. But I was interested in science and medicine really in high school. And I don't really remember what the genesis of that was and why I got interested. I mean, I was an athlete, so I was definitely interested in, what I was putting in my mouth and exercise and working out. So it probably stemmed from there. And that makes some sense. And I was good at science. So, and the nice thing about my family, despite no one having went to college, they never discouraged me from anything that I wanted to do. If I said I wanted to be a doctor, no one said, "Oh, you can't do that." It was always like, "Of course you can do that." So maybe a lesson there is don't let people discourage you from what you want to do. And then I never lost that interest. I went to a small college that really churns out doctors and lawyers. So it was a good environment for me to be in. When I went to University of Pittsburgh for medical school, it was an awesome experience. I really loved it. But I felt a little lost because as far as thinking about a career after medical school, so what training was I going to take? I really didn't have anyone to mentor me. And as a former athlete, you often get pigeonholed into, oh, you're going to be an orthopedic surgeon, you're going to work in the emergency, you're going to be an emergency room doctor. You tend to get labeled. I didn't really like that. I wanted to be able to take care of, if my family had a medical question, I wanted to be able to answer that and be able to guide them. And so I was really drawn more to internal medicine as a pathway to start. And I actually met a physician at Pittsburgh, William Hudson, who's now at West Virginia, but he was awesome. So I just went to him after I took my GI physiology class and asked him if he would be willing to meet periodically and just give me, counseling as to my career. And like every month or every 2 months, we would have lunch and he would give me advice. And it was really amazing. And he happened to be a gastroenterologist. So your mentors, you tend to be drawn to people that have personalities that are like you. And then when I went to residency at Maryland, again, I was drawn to the gastroenterologists. Their personalities sort of fit with mine. And I liked it. But I also liked cardiology. I liked pulmonary critical care, but it was really the personality types. And that's how I got into GI. And then, Crohn's and colitis, I actually wanted to be a hepatologist or liver doctor. I was really interested, but once I started my training, I liked doing procedures. I liked, having a break in my day and not just doing thought-based stuff all the time, being able to shift gears and do some procedures. And so Crohn's and colitis became a really nice option for me because it was a chronic care model. I still had to use my brain. I still had to be an internist and take care of the whole patient, not just their terminal ileum. And I still got to do procedures which are enjoyable and can be challenging. And I like the idea that my patients were going to be younger in general. Death and dying is not something that I really like. So being able to take care of people in the continuum and having them sick and being able to get them back to work and play and having family, I found that really rewarding and helps keep me engaged and interested.
Thank you, Dr. Cross. I think Robin froze for a second. Let me see if she's back. Okay, no worries. I'll continue until Robin connects back on. Just to switch gears, I also want to talk about, I want to ask you as well, what are the most challenging aspects about working in gastroenterology?
Right. Currently, the challenges are medical therapy. I'm just going to be honest. In the last year, payers basically colluded and decided that they were just going to start denying any non-standard dosing of medication, even if a patient had been on it for years doing well, they were going to deny. It's put incredible pressures on providers, and I'm sure it's not specific to gastroenterology, but for Crohn's and colitis, it's a huge burden. And I'm lucky because I have all these resources that we've accumulated over time to help. We have, there's more and more patients with Crohn's and colitis that want specialty care. So, there's a desire, patients have a desire to be seen by people like me. There's only so many of us. So, and patients don't want to wait 3 months to be seen, which is completely understandable. So access, medication access is an issue. Burnout, we have electronic records and the electronic record never stops. So we call it pajama time. Getting on a computer can be really high burnout. I try when I'm home to be home and put my phone down and not to get on the computer as much as I can, because you do need time for yourself and for your family and for your friends. So that can be a big challenge. There's more, but I think the biggest ones are burnout, medication access and fighting with insurance companies, and just not enough of us to go around. And I'm hopeful that the people on this call are going to go into medicine, because I don't want those negatives and barriers to discourage people from doing it. My boys have seen me do this their entire life, and fortunately my oldest wants to be a physician. So somehow that didn't discourage him, but I don't want the future of medicine to be discouraged from doing this, because it's important. And it's really rewarding to have someone who's sick and have them become well because of the things that you've done. It's super rewarding. I'll just give you an example that when I was very first started, I had a pregnant patient who had a bad colitis flare, and she was basically transferred to our center because they told her that they wanted her to have a abortion so that they could take her colon out, which is not unreasonable, but she wasn't ready to do that. So she came to us. I gave her medical therapy that worked, and I saved her colon, and we saved her daughter, who is now a state champion runner who's going to get a scholarship as a track athlete. So, that's a colon I saved, but, a unborn child that was saved and has a really awesome life. So you can't get much more rewarding than that. So hopefully we'll continue to have good people like you guys that want to be physicians.
Really incredible story. Hopefully learning from people like you will help create more resilient people going into medicine, because they'll have a better perspective on the upsides and downsides before they get into it.
I hope so.
Can you walk us through what a day in your life is like? How do you split clinical and teaching responsibilities?
So most gastroenterologists are going to be primarily clinical. So your split in time is going to be 4 out of 5 days are going to be doing something patient related, whether it's procedures or seeing patients in the office or seeing them virtually. I'm a little different because I'm more research focused. So I'm probably more of a 65-35 split. So Monday mornings are typically virtual visits, and then the afternoon is dedicated to research and administrative things. Tuesdays are clinical days. Every other Tuesday is endoscopy, and then the alternate Tuesday is in-office visits. Wednesdays are pure academic, so again, research or clinical. Every other Thursday, I do a full day of endoscopy, and then the alternate Thursday is typically research, and then Fridays are typically in the office. And as far as teaching, we do have student teaching that occurs in the springtime for GI, where I used to give lectures, but now the younger faculty give the lectures, but I do small group teaching for the case-based learning and so forth. And then a lot of my teaching is bedside. So yesterday I had a fellow in the office with me, and each patient we're seeing, we're doing some teaching where I'll say, you should pull this paper because it's relevant for this patient. Or what I've become a habit now, at the end of a session, I'll ask the trainee, whether it's a resident or fellow, I'll ask them, what did you learn today? And what questions do you have? And so on the way home last night, I spoke to the fellow about how I manage patients who have had intestinal resections and how I manage their diarrhea or their stoma output. And we spent like 20 minutes just discussing how I manage that. So that's the majority of my teaching. And I teach for research. So many of the projects that we do have a student, resident, or fellow that are working on the project. So I give them instruction there as well.
Is your research predominantly clinical, or do you have a basic science lab?
Now, you don't want me to do basic science research. When I was a trainee, the model was in your second year, you spent 6 months in a lab with one of our researchers. And it was pretty clear to me early on that I sucked at that. That was not what I was going to be good at. So no, I do purely clinical research. And sometimes there's going to be a translational component where we could look at biospecimens or things like that. And I have some things that I'm involved in, but that's not what I'm good at. So I'm patient-oriented research, not bench research.
Okay. And we were also curious to learn more about the podcast that you co-host called the IBD Drive Time with the Gastroenterology Learning Network. Can you tell us a little more about your work on the podcast and what that experience has been like?
So, it's interesting. On a day-to-day level, there's so much work to be done, and you're also trying to balance like what I need to get done, and I want to get home and be with family and so forth. So it's really a delicate balance. But oftentimes where I get ideas, research or otherwise, is when I'm in a meeting and I'm listening to someone present, and I'll get an idea, or even with friends from other institutions and we're having dinner or drinks where ideas will formulate. And so I was at a meeting and I was just thinking like, I should work with my friend Millie Long at UNC, and we should see if there's interest in doing a podcast, and we could do it a couple times a month. And, we can have different faculty talk about various topics, some research they just published, or like a new drug that was approved this week. We could talk about positioning. And so we got the Gastroenterology Learning Network and Advances in IBD interested, and they've been sponsoring us. And it's been pretty popular. I call it a drive time because that's when I listen to podcasts. So, I listen to the daily typically when I'm driving to work. And the idea was most people's commutes are going to be 15 to 30 minutes. So we wanted to make it that length so that it would be someone's commute. And it's so interesting that whenever I listen to these ahead of time, before they're published, it almost is always from the time I get into my truck and walk into the door at work, the podcast starts and ends. And we don't try. I mean, we obviously try to fit it in, but it's just so interesting that it works out like that it fits my drive time perfectly. So that's how we named it. And so it's fun to do. We get to talk to friends and they can highlight the things that they're good at and teach people. And it's been fairly popular. We now have an industry sponsor that's interested in sponsoring a few of our episodes. So it's fun.
What's exciting about the sponsor?
We've been doing it for basically, we've just been donating our time to do it because we like doing it and it's interesting, but it'd be nice if you got reimbursed for your time. But we, Millie and I like it enough that we would keep doing it even if we weren't getting paid to do it. But it's always nice to get paid for your time. But there are some things that you do that are just so fun or so meaningful that you just do it for free. And so IBD drive time is one of those things.
So you briefly mentioned balancing work and life. Can you talk a little bit more about how you manage that?
It's hard. So, I don't want you to think that medicine is an 8 to 4 job because it's really not. Certainly you can make it that, but it's longer hours. There are things I need to do in the evening. They're not as much patient related, but they're more academic related when I'm doing that. And it's hard. You have to prioritize, what's important to you. And I think the best thing that happened to me is about 10 years ago, I realized I needed to make a change. And I really had to be more present because when I was home, even though I was home, I wasn't home. I was still thinking about work and building our program and the next research project, and I wasn't present. And so what I started to do is, first of all, I limited how much I traveled or went to give a talk or went to do something for research. I limited it to twice a month. And I put my phone down at night. I put it face down. Eventually, people realize that you're not going to respond, that you're just not available. And patients are going to realize, like, I'm not going to email or send a message because Dr. Cross isn't going to be looking at this time. And it definitely made me a better husband and a better father, and probably preserved my interest and desire and prevented burnout. But you're going to have to make some sacrifices. If I want to work out, I have to work out on the weekends. I have to get up early before work and typically get my workout in. So there's sacrifices you have to make. I do more with my wife and my kids than I do with friends. And actually in the pandemic, I think that's one of the reasons that I sort of was a little down in the dumps and bluesy, is what I realized is when I did those things that were outside of the house that were work related, over 18 years, I had made all these friends that were outside of my institution. And when I would go do those things, I would have social time with them. And that was a friend network that I didn't get to see basically for 2 years. And when we started to do things in person again, like my mood was, elevated because I was able to start to see people in person and not on a computer screen. And it was really helpful, but it's a balance, women in medicine, it's a bigger challenge because, they're having the babies, not the men. And so they have even more pressures on them. But it's still worth doing. We're just not 9 to 5 people. That's not our job.
So that was our last question. Thanks so much for giving us your time today to share your knowledge and perspective.
Sure, my pleasure. I'm happy to do it. Hopefully I haven't discouraged you guys from becoming doctors.
Thank you very much, Dr. Cross. I know that we were all very inspired from your story and really appreciate you taking the time to answer all of our questions and taking the time out of your day to mentor us. And I'd love everyone to please give a warm thank you to Dr. Cross in the chat box for this incredibly informative session. Thank you.
All right, guys. Thank you for inviting me. Have a great day.
Thank you. You too.
Bye.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live, and you need a 70% or higher, as always, to pass and receive certification. And the link to the quiz is being sent in the chat now. Many of our students have also expressed interest in pursuing a leadership position in teleshadowing, so we've reopened our leadership applications for students interested in joining our team as well, and that link is also being sent in the chat. So now for our next session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, March 26th at 10 a.m. Eastern Standard Time, with our physician mentoring us in internal medicine. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.